Hello, and welcome to another episode of Craig International on the Go. I'm pleased to be joined by Dr. Gregory Furman. And I wanted to ask Greg, for this particular topic, how do we approach this in patients? Because there's a number of different anticoagulants. How do you approach bleeding in these patients to get a baseline, if you will, for care to make sure that they're properly resuscitated?
Thanks, Brian. So I think the initial approach to a hemorrhaging patient that is on some sort of anticoagulation is to first do some assessment of clinical stability. Certainly that's going to be vital signs, find out their blood pressure is low, and then other clinical features of hemorrhage such as impaired mentation, diaphoresis, sweating, those kind of clinical features that we look to if somebody's getting acute hemorrhage. After that is established, and perhaps the patient is not exhibiting any of those features, then you're going to try to embark on source control. So if you've got an obvious source of bleeding, such as a hemorrhage to an extremity, you might deploy source control with a tourniquet, for instance. If it's more internal bleeding, you may want to get consultants involved, such as an endoscopist or a GI doc, to talk about maybe upper or lower endoscopy. If it looks to be a solid organ kind of injury, either traumatic or atraumatic, you're going to look to a surgeon to help you with that. But ultimately, you're going to deploy a fair number of diagnostics to help you find this out. It's not going to be readily apparent unless they have a hemorrhage from a laceration or something like that. So CT plays and cross-sectional imaging in general will play a big role here in terms of that. And then you're going to start embarking on resuscitation. So probably simultaneously to diagnosis, you're going to embark on resuscitation. So resuscitation initially would be 2 large bore IVs if you have those available to you. If IV access is limited, you might consider an intraosseous line or something to that effect. And then you're going to start with initially resuscitation with crystalloid, volume expansion maybe there, and then moving quickly into packed cells or whole blood, depending on your institutional policy and the magnitude of the bleeding, and then dial in FFP or platelets as dictated by the patient's trajectory. Those would be the kind of the uniform approach to a hemorrhage patient that you might see regardless of anticoagulation status. Ultimately, most of the bleeding episodes that you see in somebody that's anticoagulated fall in the category of clinically relevant, meaning they come to the emergency department for care, but not major, such as a nosebleed that might be able to be packed or have a tamponade device deployed, or something that can be oversewn on the skin or soft tissue. So usually this bleeding is more considered clinically relevant but non-major. Some people call it nuisance bleeding, although it's not a nuisance to the patient, obviously.
Not a nuisance to the patient,
right,
for
if
sure.
they're coming to see you. So, but should it fall into the major category, then you really have to kind of bring a lot of diagnostics and start deploying some resuscitative features.
Well, that's really important, basically, to give that underscoring of here's how you will treat the patients before you even start thinking of specific reversal or what the anticoagulant is that you have to get that patient where they are able to tolerate this bleed. And so that's very important information that you provided for that, Greg. Thank you very much. And thank you very much for watching Craig International on the Go.